to the success of the Society. I would like to take this opportunity to encourage you all to join BAJIS. Membership is free, which is a welcome change for a specialist society, and we'll keep you updated on upcoming events, for example, our next annual Congress in Coventry, and we would hope to see many of you there. This evening, we're privileged to have a group of distinguished speakers who really are leaders in the field, and so it's my pleasure to hand over to our current BAJIS President, Mr. Rhidian Morgan-Jones, who will do the introductions. Over to you, Rhidian.
Ian, thank you. It is indeed a pleasure to have our third BAJIS webinar and to have such a wonderful group of guest lecturers. I'm at my advanced stage. I'm really excited, but tonight's programme I've been looking forward to for a long time. We've got Dr. Joshua Jones from Dundee to talk about Phage therapy, Dr. Simon Garceau from Ottawa to look at PGI trends in North America, and our first talk is Professor Fares Haddad from London, who's going to give us a realistic outcome on PGI surgery. I'd also at this point like to thank our sponsors, Mulnica, who will be giving a short presentation later. So if I could introduce Fares Haddad, one of the key opinion leaders in world orthopaedics, and I'm really looking forward to see what he has to say about infection outcomes, which I think is a much neglected topic. Fares.
Thanks, Rhidian, and thanks, Ian, and thank you for having me on this webinar. I hope you don't ultimately regret it. So I've been given the task of talking broadly about outcomes, and my focus, like my clinical practice, is going to be on hip and knee arthroplasty infection, although I recognise that the membership is much broader than that. But I thought I would stick to the area I've worked on and understand. We always show our disclosures. My disclosures are inevitably relevant. I think one key one here is that I'm editor-in-chief of one of the big general orthopaedic journals. And although I speak as myself this evening rather than editor of the journal, my views are inevitably shaped by the literature that I see and have to deal with on a day-to-day basis. So just setting the scene, if you like, I have a very tainted view, having spent over 10 years as an editor of a journal, that the literature as a whole is actually horribly flawed. And as you'll see, I feel that's particularly the case in the infection world, and that we should be working to improve it. There are many reasons for this, but in reality, one of them is that the publication world has evolved dramatically with open publishing. And this has huge benefits in terms of accessibility to research, but it has a downside in that there are too many journals and an increasing number of predatory journals. And that means that everything gets published somewhere. And I'm sure my colleagues speaking after me, all of whom are distinguished experts in the field, may partly fall foul of occasionally referencing some of the material that probably should not be in print, but suits the case that we are supporting at the time. And so it comes down to you as a discerning listener, reader, or person trying to guide the care of your patient to differentiate as to what is credible research and what's junk science, because there are no perfect controls out there. And this is a real problem in the infection world. It's always been worse than other areas because of the underlying heterogeneity that we have to deal with. But beyond that, in this world that we all live in and are trying to improve, there really isn't uniformity of definitions or interventions. As I'll come back to, there's a massive fidelity problem. And my big concern is there are huge reporting problems. If this wasn't enough, more recently, there have been big economic drivers as the focus has come in on this area, and some personalities that have driven the literature and hence the thinking of many in perhaps a direction that it would not have gone in on with sensible, proper peer review. I'm going to come back to this paper, but I thought I'd put it out at this point as a taster. This is a fantastic piece of work from Carsten Perker's group, looking at the German registry and linking it to other databases in Germany. So it's not just the arthroplasty registry, but it's looking at their insurance data as well, so that you get real tangible outcome, because the insurance data is complete. And in reality, what this study shows is that what is reported in the literature doesn't seem to correspond with what they are finding here. Some real question marks on the material we all rely on a day-to-day basis and regularly reference. Now, the problem goes deeper than that, of course, because we have even struggled to define what an infection is after arthroplasty. This is, for me, what is the standard now, and congratulations to all the colleagues who've contributed to this at EBJIS. This should be what we're all using. We were, not until not too long ago, using the MSIS definition of infection from 2013, and we were all comfortable with that. It was logical, it fitted in with our practice. Samu Sedic and I, with Ian Stockley and Kate Gould, made the mistake of suggesting that a numerical system might be added to this, and I still think it is a sound suggestion, but what we didn't have in mind is what happened in the lead up to the 2018 consensus meeting, where a numerical definition was created that suddenly put D-dimer and alpha-defensin at the heart of infection diagnosis and downplayed culture. Many of you will know my views on this. Remarkable that D-dimer data was suddenly available from so many centres in particular, and remarkable after all these years that we've downplayed infection. But I think it's a key message here that if we cannot agree the definition, then we have a problem. So for the time being, I think we have a workable solution with the EBJIS definition, but unless we're all reporting to the same metrics, we're going to struggle. And right now, worldwide, we are not reporting to the same metrics. The other issue I mentioned at the outset is fidelity. So we talk with great confidence about incision and debridement, DARES, excision arthroplasty, arthrodesis, and all the modalities available. But in reality, a DARE in one set of hands is very different from a DARE in another. And a single stage revision in my hands and in somebody else's hands is very different. It's not just the technique of the surgery, it's the perioperative care, the microbiology input, the plastic surgery input. There are multiple variables, but even just the basis of that one-line descriptor is questionable because it is not the same across the literature. The best example here is in terms of incision and drainage, washout, debridement and implant retention. There's a murky cloud in between all of those that makes all the summative analyses of them really tricky to put together. The next piece is how we define success. In reality, many people have tried to do this. This particularly lauded paper doesn't even have the patient perspective in it. It is purely a microbiological and surgical definition. And it's been one of my gripes in the infection world that the patient perspective should be front and center of everything we do. Like everything else in the literature, when we're really trying to define success, it should have a patient-centered focus, and that hasn't been the case. The other issue here is the outcome of the infection versus the outcome of the arthroplasty. The two may be very different, and this has pushed us in a treatment direction that favors dealing with the infection, often to the detriment of the patient and their function. And those two needed balance. We've also failed to standardize for follow-up. So there should be a minimum follow-up period for any infection reporting. In arthroplasty without infection, we look at least 2 years. In reality, we didn't even report our initial single-stage experience until we had 5 years. And I think there should be a significant minimum period that we all agree on. I'm a great believer that you get infection control. I don't think you ever really get eradication, but I can't get everybody to agree with me on that. I think we really should focus, as I mentioned, on patient function and happiness rather just on whether there is an organism or the patient requires antibiotics or further surgery. And so we failed to set adequate reporting standards, and that is something that we must fix. We, of course, have good literature. This is a paper from one of our chairs on single-stage revision, but they're largely case series, and they've got questionable fidelity in terms of other people doing the same procedure the same way, and so those results may not necessarily be transferable to everybody else out there. There's plenty of them. They build our experience, they build our thinking, but I think you've got to just remember that what happens in those centres isn't necessarily what happens in every hospital. The reason I mentioned that is not to belittle any of these papers. I think they're excellent papers from hardworking people in good centres doing good work. But where it becomes questionable are when people, including myself, try and do a summative analysis of these papers when they're adding together apples and bananas and various other fruits, putting them all in a mix and trying to reach conclusions. Those are real problems. Then we get on to the outcome measures. So if we focus, for example, on infection control, if we can agree what that is, we need to remember that there are other variables at play. And we, certainly as a surgical community, have largely ignored morbidity and mortality. So it's only recently come to wide understanding that those proponents of two-stage revision, for example, the standard accepted approach worldwide, were largely losing a chunk of the denominator between stages, either due to morbidity or due to the patients not wishing to come back, or frankly, due to mortality. And then the later mortality wasn't even considered. So success needs to look at the entire denominator and not just those who went through to the second stage. We're very fortunate in that there are now some RCTs and some really good clinical RCTs. The Inform group have done a wonderful job. Tom Ferring's group is about to get to their 2-year data. And I think this really helps and frankly is changing practice. I've had a big focus on popularizing single stage revision. I think I've succeeded to a certain extent in that I now go to North American meetings where single stage revision is a procedure invented in the United States. That makes me very, very pleased because we've really changed practice through these studies. And there are some useful guidelines that have come out from the information from these studies on top of the qualitative data that we can take away. Now, a brief word about registries and databases because they're out there and they've become a key resource for us to look at data and outcome. They're easily accessed. I think you've got to take away from this that although I'm going to give you one great paper that I've already mentioned, these are largely flawed in relation to periprosthetic infection. Just think of it in simple terms, and we've written on this previously. The data that goes into the registry is recorded at the time of surgery. It doesn't separate deep or superficial infection. It doesn't delineate exactly which procedure the patient underwent. It doesn't have the microbiology data. It doesn't have case mix adjustment. Now, of course, there are new registries trying to address this, but in the standard registries, we know there was a poor pickup that was 40% or less. We've, of course, learned a great deal from the registries when you look at the baseline demographics. So looking at the number of people who are having infected revisions, that is helpful, of course, or looking at morbidity, mortality, etc. Afterwards, there are some metrics in the registries that are very useful, but you've got to remember the denominator may be completely right. And then there are failings. This is a reasonably well-written paper from New Zealand analysing the impact of ultra clean air theatres, amongst other things, on infection rates. Now, little did we know at the time that what it recorded was whether there was an ultra clean air theatre in the hospital, not whether it was in use or not. It didn't record how it was used, and there were multiple variables missing. And of course, the capture of infection was incomplete, as I've just shown you from the Danish registry. But the conclusion of those papers have led to guidelines belittling laminar airflow ventilation for orthopaedic theatres. You may be on one side of this equation or the other, but I think when those papers based on big data lead to big guidelines that change practice worldwide, we do have to be a little bit cautious. I come back to this paper because this is Carsten Perker's work. Remember, linking the foolproof insurance data with the German registry, which of course doesn't have 100% capture, but has pretty good capture. That data goes completely against what is in the single hospital reports and the meta-analyses from Germany. And that would suggest, at the very least, that the data from big centers isn't transferable elsewhere, and hence we should be centralizing and looking at different models of care. At the worst, it suggests that patients are traveling, getting treatment, and their definitive outcome isn't being reported by the original center, who have deemed them a success when the patient has decided not to come back because they've already had their treatment there, and failure means their secondary treatment will be local. So lots of tricky corollaries here and stuff we need to look at. The last facet that we tend to look at is consensus, and I think the 2013 consensus was a huge success. It's a great way of hearing from everybody, involving everybody, and getting a good conversation. But I think you've got to be careful with consensus. There's another on the horizon next year. There is a subtle difference between evidence and opinion, and there are some drivers behind this that can easily manipulate the output. That was certainly the case in 2018, and whilst I think consensus has helped us massively in this area, some of it does need to be taken with a pinch of salt. I think one key thing when we're looking at evidence, looking at the literature, looking at outcomes, is to look for concordance. If we can see similar data and similar outcomes across a number of different types of studies, be they case series, then onto control studies, onto RCTs, and then onto the systematic reviews or the big databases, the observational data sets, that is very helpful, and that will suggest we're moving in the right direction. Having said all of this, I think sometimes the best evidence is experience. BAJIS, or the related group, has a WhatsApp group, and actually some of the best advice, and occasionally some of the not so good advice, comes through there, but actually the experience of people who have treated infection for the last 20 or 30 years often trumps what is out there or easily accessible in the literature, because there's nothing like knowledge, experience, and having done it over the years. So there is a mixture here that you need to bear in mind when you're looking at outcomes. And we still have much to learn and much to research to have it all out there and discoverable, and to transfer what Rhidian has learned in the last 25, 30 years into something that everybody can reproduce. So just to conclude, this wasn't designed to please everybody. It is designed to highlight that there are real problems out there. I think on the positive side, we have made tremendous progress in the last 20 years. We've really put a focus on infection, and that's important. But in so doing, there have been some pretty dramatic mistakes, and some of them may have been done in all good faith, trying to improve things. My message to you is that much of the literature is flawed, and you've got to be incredibly careful in this area, both unpicking what is behind the studies, what is behind their data, and some of the drivers. And some of the recent initiatives are questionable, like moving away from culture. I think we've got to really look at how we want to go from that point of view. Above all, we need to all standardize how we collect data and how we report it. If we don't set minimum standards, outcomes that everybody needs to collect, we're still going to be looking at a mishmash of data. And that would be unfortunate as we progress in this area. But this is an important area for us to focus on, and it is great that Ian, Rhidian, and others are driving it so well. Thank you very much.
That was excellent. Thank you. As stimulating as ever. And I couldn't agree with you more on so many things, and in particular, the patient perspective. And it's interesting that hopefully you've seen, as I have, there's a group of us now of a certain age, certain vintage, who've done everything you said, made all the mistakes that you mentioned. God knows I've done them. But now the focus has changed towards the patient and putting them uniquely at the centre of what we do. How strange is that?
Well, it's so logical. I mean, I can remember falling off my chair when a young, very bright, now eminent orthopaedic surgeon presented the 5 criteria of success in periprosthetic infection management, and the patient wasn't mentioned in them. I think you were sitting next to me, Rhidian.
Yeah, absolutely. Fares, can I ask you a quick question? I agree that you said, and you mentioned experience, and one of the unique things about the UK now is revision networks for knees, and it'll be rolled out from knees to shoulders to foot and ankle to hip. Do you think that's going to make a difference if we centralise and have a genuine regional MDT so that everybody talks to each other, experience is transferred, patients move with the experiences?
So I think the concept is right. The analogy is awful. It's been one of the worst done political stunts in British history, the revision knee network. And I can't think of a worse example of mismanaging colleagues and abusing trust. But in reality, the concept of centralizing and having expertise in areas that can deliver this care. And this is not doing down surgeons in small centers. This is just basically making sure that everybody is centered around the patient and giving the patient-centered care you're referring to. So it's about having the right ID, the right microbiology, the right laboratory, the right, frankly, the porters who can get the samples with the right samples from theatre to the lab. It's about having the meetings, the feedback, the learning. And if you have more volume, you have more learning. So there's no question, Rhidian, that centralization and having a focus on infection in very specific centres, although it's complicated sometimes in the early presentation, how you get the patients there, is going to be the way forward. I'm sad about the way it's been done in the UK. It's been done much more nicely in France. We're pushing to try and get some traction with it through Tom Ferring and others in the US. But no question, Oxford led the way. You know, we've had an MDT for 25 years almost now in infection that's been advising externally as well as internally. I think there's no question these are complex cases that need to be centralized.
Thank you. I agree. Ian, do we have any questions from the delegates?
We do. Just one point, Professor Haddad, thank you. That was a superb talk. As you really nicely discussed, one of the big issues with infection literature is the multiple factors that ultimately influence outcomes. You know, patient, organism, MDT inputs, the surgery itself. It's therefore difficult to tease out which steps ultimately affect success. Can we overcome this with high quality evidence, or do you think we need to?
So I think we're getting better at capturing data, and if we have data capture that is broad enough in a big enough number, we will start to be able to unpick this. There'll always be unknowns, and there'll always be descriptors that we're not picking up. But I think this is where bigger data sets, and whether you can ever get registries that are deep enough. I mean, I remember having discussions with Mike Reid before the infection registry was set up, because I thought what you really needed was even deeper data sets, and that you should collect them from the 8 biggest centers or the 10 biggest centers and focus on those to have real depth, and then be able to go in that and then translate that. And that's where big computing will come in, etc., to be able to do that. So I think the answer to your question is that I'm not sure we're anywhere near there, but the only way we're going to get there is by capturing lots and lots of data and being able to then look at outcomes for that data. And that will need everything I talked about. It'll need good data capture at the front end, and it'll need very clear outcomes and very clear reporting at the back end.
Perfect. 2 questions from the audience. Firstly, the question is, do you see any role for AI in filtering data and investigations to have any impact on the diagnosis of PGI? And do you think that AI can replace a surgeon's experience?
Not at the moment, but I mean, AI is going to do lots of things. It is so exciting, and it can look at big data sets. So I think the answer is yes. I think there is a role here at looking at a number of metrics and trying to guide you in the right direction. Before we get there, there'll be a number of black boxes sold to us as part of the economic game behind infection that actually won't deliver this properly. And so I think we've got to be cautious there. So this needs to be, like all AI innovations and AI research, can have to be looked at really critically. But I think it will absolutely have a role to play. Will it completely replace surgical experience? You know what? I really don't think so. There is something you get from treating infection for 25 or 30 years that just gives you a pattern recognition and something you learn from everybody around you that right now I think is difficult to replace. I hope I'm not proven wrong, but I think that's the little bit of value I add to my team in order to do that. Mike Reid, I think, or someone called Mike R, has just piped in that can't see AI being useful. Data sets are too small. I think the challenge is actually his registry and a bunch of well-reported studies from multiple centers in a world of open data where all the data is uploaded is actually going to be the answer. So I hate to disagree with Mike Reid. That means I'll be excommunicated yet again from the infection world. But I think, Mike, it is something we need to be able to do, and open data will help with that.
Superb. One final question. It's interested in your infection control rather than cure idea. Are you suggesting that different bugs can hide more or less well, perhaps for years?
Absolutely. So I think 2 things here. I think the first one is people report too short term and things come back to hurt them. And increasing antibiotic time, and you think you're doing well, and then bang, the problem comes back to haunt you. So the more you follow up your patients, the more you discover problems. But the other thing is, I think bugs lurk in all sorts of strange places, in canaliculi, in places you can't see or can't get to. And when we talk about radical debridement, we try and do a really good job of taking away everything that we think is abnormal. But as Vanya and others who are experts in this field know, there'll be a staphylococcus lurking somewhere in a deep, dark corner you just can't get at. So yes, there are differences, and I really feel very strongly about that. Anybody who says eradication loses me, that's the rest of that talk gone. So I warned the next two presenters.
Well, that's good to know. Thank you so much, Professor Haddad. It's, again, absolutely superb. I'm going to hand over to Rhidian to introduce our next speaker.
Excellent. Well, that's certainly set the standard for the rest of this presentation webinar. Fares, thank you so much. Our next speaker is Dr. Simon Garceau from Ottawa, who is going to talk about emerging trends in PGI in North America. And one of the things I've always thought is that, it is geographically different around the world, and our European experience may not be directly applicable to North America or to Asia or elsewhere. So I'm very interested in your thoughts on this. Simon, the field is yours.
Thank you very much for the introduction. Perfect. So hello, and thank you everyone from the Bone and Joint Infection Society, and specifically also to Ian for inviting me to present today for your section on periprosthetic joint infections. I'm Simon Garceau. I'm an orthopedic surgeon working at the Ottawa Hospital in Canada as an adult joint reconstruction surgeon of the hip and knee, and a member of our Periprosthetic Joint Infection Service. I was tasked today with providing you with an overview of PGI care in North America, and so I'll try to do that with a little bit of a Canadian spin on it. Next slide. So although I have some disclosures, really the most relevant disclosure for this presentation related to PGI is that I received research support from a company involved in PGI irrigation solutions, notably Next Science. So first, I'll provide a brief background about me, as I don't have the same reach and circuit tour as my predecessor, Professor Haddad, who you probably all know very well. Then we'll discuss the current North American models of care and where we're headed. Followed by, since I'm Canadian, we'll discuss PGI regional care within Canada. And lastly, we'll highlight PGI research, which has led to regional evidence-based changes in treatment patterns, as well as national collaborative efforts in PGI care. So first, a quick overview of who I am. I'm a French Canadian who grew up in Quebec City, which is the French portion of Canada on the East Coast. I then completed my orthopedics training in Vancouver on the West Coast, which is where Ian is currently situated doing this fellowship. Followed by some fellowships in adult joint reconstruction in New York City and Toronto, which is where I really developed both an interest and exposure to PGI care and research. So now let's focus on current and emerging models of care in North America. There's this decisive evidence for several orthopedic procedures that surgery performed at high volume centers by experienced surgeons translates to superior outcomes. This is certainly true as well in PGI care, including for procedures that have been traditionally deemed as quote unquote simple, such as debridement, antibiotics, and implant retention, which we assessed at our center, where the odds of success was noted to be 2.5 times greater if a patient was treated by surgeons with subspecialty training in arthroplasty. So traditional models of care in North America have included both total and partial care of PGI patients following diagnosis at non-specialty centers, which we know also leads to inferior outcomes, which is highlighted in the study performed at the University of Toronto. As such, similar to what has or is being done in Europe, the North American standard for PGI care is shifting with a focus on early referral to specialty centers to obtain definitive care. with a focus on a concept that I'm sure in the NHS you're all too very familiar with, this concept of quote unquote getting it right the first time. Furthermore, there's been a shift within tertiary referral care for PJI, albeit slower than probably in Europe, towards treating PJI like tumors. So that's to say, via highly organized multidisciplinary care at quaternary PJI specialty referral centers. Such models have been developed with the patient at the center of a core team of allied healthcare professionals, in addition to regular consultation with additional key players. Similarly, this model, this is how we've organized our multidisciplinary PGI specialty service at the Ottawa Hospital, which is both the first and only of its kind in Canada, and also the first to develop a fellowship program with a focus on PGI care. This service is led by 3 orthopedic surgeons with clinical research led by my colleague, who you probably know, Dr. George Grammatopoulos, and myself, and PGI basic science research led by another one of my colleagues, Dr. Shyam Abdulbari. From a basic science perspective, our center has a PGI-focused laboratory led by Dr. Abdulbari, with recent work in developing a validated rat model for PGI using monoblock 3D printed titanium hemiarthroplasties, which won the 2021 Frank Stinchfield Award from the Hip Society. So just to put things into perspective, these implants are really small, and that's a scaled picture there outlining the size of the implant. Certainly, however, Canadian healthcare is quite different than that of our American counterparts. Notably, we are, for the most part, a fully publicly funded healthcare system, and as such, there are significant differences in PGI treatment models and the challenges we face in providing care. A big issue when there is a limited pool of taxpayer funds are the costs and resource utilization incurred through providing multidisciplinary PGI care. So looking at the direct inpatient cost of PGI care, for example, this represents a cost that's 2 to 3 times the cost of a similar aseptic revision. Moreover, when we look at our own data from the Canadian Institute for Health Information, has determined that PGI is the top reason for early revision surgery within the country, or in other words, 1 out of every 3 revisions performed. Similarly, the average cost of a 2-stage revision in Canada is roughly about 35,000 Canadian dollars, but it can reach astronomical numbers, or greater than $1 million, when patients stay for a prolonged period of time and require multiple surgeries, with greater than 50% of the cost resulting from inpatient care. So this is simply just a snapshot highlighting the length of stay of a few of the patients that are currently on our PGI service. As you can see, patients are staying very long periods of time, and this is probably one of the shortest that we've had in a while. And so it is very costly to the hospital and to our healthcare system. So due to the nature of our healthcare system in Canada, we certainly see many parallels with our European counterparts and have leveraged elements that have worked elsewhere with similar budgetary constraints. I'm glad Professor Haddad mentioned this model in France. So one such model that has been that of France, where care is delivered in a regional fashion, as reported by one of our colleagues, Tristan Ferry, in Lyon, where care is provided from a regional perspective with champion or quaternary care provided at Centre de référence aux infections osteoarticulaires complexes, as well as multiple smaller regional partners highlighted here as corresponding partners that communicate with these champion centers. The goal of regional care, therefore, is to facilitate multidisciplinary care, facilitate referrals, and disseminate information and guidelines to regional centers. It's also serving as a platform for research and providing graduate level bone and joint infection certification, which is a similar model that we've attempted to adopt in our region. Furthermore, to address the major challenge of financial disincentive faced in providing multidisciplinary care via PGI specialty centers, an alternative funding plan has been proposed, which we similarly hope to adopt regionally. This model is based on a points system focusing on host criteria, microbiological criteria, surgical criteria, as well as relapse. Such a system highlights the need for more equitable funding for more complex patients. Regionally, we're developing a similar system of PGI care under the umbrella of a term that we've coined a community of care. So the PGI service is organized in a similar fashion to TOH, with a PGI surgeon on call every day of the week to provide guidance and accept direct, streamlined referrals with care provided through all phases of treatment in a standardized fashion. So some key points of the service include 1, multidisciplinary clinics, 2, dedicated specialty surgeon PGI ORs every week, and 3, standardization of care for PGI patients. To further outline the model of regional care in Canada, this is where we're situated in the southeast of the country. And within this small ellipse that I've drawn here, we have a concentration of about 50% of the entire population of the country. And so that equates to about 40 million people. Within this densely populated region, we service all of Eastern Ontario. So essentially everything east of Toronto that you see in the bottom left corner of the map here, going into the neighboring province of Quebec, which is the French part of the country. To put this into perspective, this area represents a population slightly below that of Manchester and includes multiple community orthopedic hospitals outlined by yellow stars here, as well as a number of affiliated, drawn in red here, and unaffiliated, drawn in blue, academic centers. Such a regional initiative has allowed for the development of a prospective PGI database, allowing us to track PGI outcomes in real time through the collection of patient-reported outcome measures and mental health scores, as well as quality improvement metrics. This initiative has allowed us to engage in data-driven collaborative work with other centers in North America, notably the United States. It has led to evidence-based changes in PGI care within our region, notably in how we treat acute infections of the hip. In this retrospective study from our PGI database, we assessed over 100 patients with acute PGI of the hip treated with either debridement, antibiotics, and implant retention versus partial or complete single-stage revision surgery. We did a univariate analysis, followed by a multivariate regression analysis for factors associated with failure, defined as reoperation for recalcitrant prosthetic joint infection. We noted that partial or complete single-stage revision was associated with notably a 4.5-fold increase in the odds of treatment success compared to DARE, as defined as Tier 1 or Tier 2, according to the MSIS reporting tool. This is further highlighted in our survival analysis that demonstrates the change in success over time. As such, from a regional perspective, for acute infections of the hip, our preference has been revision arthroplasty over DARE whenever feasible. And this is especially true in the early postoperative period when cementless components can be easily exchanged, or usually within the first 10 weeks after surgery. Similarly, regional trends in the treatment of hemiarthroplasty PGI have changed. As you know, this is a population which is typically frail and comorbid, and furthermore has limited reserve for additional surgery, and where treatment success rates have traditionally been significantly lower than that for primary joint replacement PGI. So the aim of the study performed by my colleague, Dr. Grammatopoulos, was to assess factors associated with treatment outcomes following hemiarthroplasty PGI. In this study, we included a total of 2,000 patients and divided into 2 cohorts based on the development of postoperative PGI. What's notable from this study from the treatment perspective is the low success rate of DARE as a treatment option and the markedly superior success rate of treatment strategy we have now employed as our standard of care within the region, which is single stage revision with a conversion to total hip arthroplasty. This technique has been recently published as part of a JBJS review, which is highlighted in this figure where A, a smooth polished cemented stem is removed, B, all visible proximal cement is burred out, C, acetabular cartilage and superficial bone, both of which can harbor bacteria, is reamed, and D, a cemented cement technique using a high dose antibiotic cement is used for the stem and a cemented liner is then inserted. Lastly, on a national level, there's been an increased interest in PGI collaborative research efforts, most notably in the area of PGI prevention, specifically surrounding irrigation solutions. So we're currently performing a study across 9 Canadian academic sites that is fully endorsed by the Canadian Arthroplasty Society, which is an RCT in primary total joint arthroplasty comparing dilute betadine to a pre-formulated acidic solution known as Experience. The solution is an odorless, pre-formulated, clear and colorless product. The primary outcome of this study is the rate of acute infection as defined as infection within 90 days postoperatively, and we'll also be assessing a multitude of secondary outcomes as listed here. And this also includes patient-reported outcome measures. The aim of the study is to recruit a total of 7,600 hip and knee arthroplasties, and we're currently, in terms of recruitment, nearing about 1,000 patients having been recruited. Lastly, we're currently working to enhance our presence in phage therapy research, with our center being the first to administer phage therapy in a PGI patient in Canada. My colleague recently obtaining a significant amount of grant funding with active partnerships in Canada as well as abroad, including in France with Tristan Perry. Thank you very much. I'm happy to answer any questions.
Simon, that was excellent. Thank you so much. I always find it instructive to hear how different regions are coping with infection and the management plans you have, and listening to you talk about your regional model and how you're centralising care. I think that mimics what we are trying to do in the UK. And the question I would have follows on from one of Fares's comments about, do your colleagues outside of Ottawa buy in readily to sending patients? Is there any risk of them not sending a patient because of whatever factors, ego, personality? Or do you find everybody's bought into your structure?
So what I would say that's interesting and why I wanted to make a differentiation between perhaps the US as well as Canada. Having trained in the US for a year, you kind of see some of the differences in how they're organized, especially around New York City, where you have a multitude of centers and everyone is trying to keep patients within their own care. When you're looking at a region, when you're looking at a regional network in Canada, it's publicly funded, so there really isn't as much of an incentive to kind of keep patients locally. And certainly what we've been promoting, and we've had regional meetings about this, is this concept of early referral. And I think, at first, there was for sure this issue with, as you outlined, ego, and I'm able to do this, and I'm a plastic surgeon. But I think the key part that we've emphasized with our regional partners is it's not just the technical ability of the surgeon, it's the entirety of the team. So when you have surgeons who are doing this day in and day out, technique becomes very important. Setup, having a dual setup in the OR, clean and dirty, which we've standardized at our center. And having an infectious disease specialist that specializes in PGI and understands what we're trying to achieve, as well as the multidisciplinary team meetings we have every week with our allied healthcare professionals is really what's making a difference. And so we're trying to work to build these networks across Canada, but certainly the difficult part is also getting the buy-in from all the allied healthcare professionals, notably infectious diseases, which we're quite lucky to have had at our center.
Excellent. And you use one phrase that's really struck with me, a community of care. And you putting your patients in the center of this community and looking after them. That's a really nice concept.
Yeah, so I fully agree as well with what Professor Haddad had said. Is certainly, we've noticed a big change, not only just in PGI care, but in orthopedics in general, where patient-reported outcomes, the patient, perspective is certainly valued, including when you're applying for grant funding for anything. You always have to have nowadays the patient healthcare advocates as part of the planning for research studies, also planning care. So it's certainly something that we've valued.
Yeah. So Ian, are there any questions from the audience?
No, we don't have any questions from the audience as of yet. Thank you very much, Simon. That was a superb talk. Very impressive to hear about you setting up the first PGI centre in Canada. I'm sure that was a lot of work, and I'm sure that would be an excellent fellowship for anyone interested. Just in the interest of time, Rhidian, I think we'll move along to our sponsors talk next.
Yeah, so if I introduce Dan from Mullica, who's going to give us a presentation on Mullica dressings, I believe.
Thank you. Let's get this up and running. Okay, thank you. So, very quickly, I'm the Business Development Manager for the Incision Care Division at Mullica. And so really what I want to talk to you about is the advanced solo. And obviously prior to surgery, you always look at the risks that to the patients, and obviously by identifying these, obviously the appropriate course of treatment can be looked at. So we sort of define this as sort of like a low, medium, and a high risk. So low, medium is sort of you're looking at your decent post-operative dressing, something like a Mepilex border post-op. If we're looking into the medium side of things, then potentially, if budget allows, you can look at closed incision negative pressure. But obviously, your higher risk patients as well. This is obviously where negative pressure is certainly looked at. So with regards to what we can offer, we have one device. We have two options, but both give them the same effective therapy. Advanced Solo, which is used for closed incision. We also have the Advanced Solo Adapt, which is a film and foam used for cavity wounds. So Advanced Solo, when it was designed for effective therapy from start to finish. We're looking to make it effective, keep it effective, and end it gently. So by doing this, obviously making it effective, why? Because obviously patients are high-risk patients, need all the efficacy available. But we do this by delivering constant -125 of negative pressure, which gives a greater mechanical effect. By keeping it effective, because obviously therapy is going to be needed 24/7, we use what we call SCFM technology, which includes things like the canister that provides obviously effective exudate management throughout the treatment. And by ending it gently, because obviously pain can impede, and obviously blistering is avoidable, we use what we call our SafeTac technology, which is clinically proven to reduce pain and obviously trauma to the wound as well. Ultimately, we're looking to send patients home with portability, ease of use, and obviously discharge support obviously for patients as well. The Advanced Solo itself is made up of 5 key components: the pump, the canister, the CFM technology, border dressing, and SafeTac technology. So we have a look at the pump. That delivers -125 negative pressure, which is a 14-day device. By using the application of -125, it doesn't actually diminish the dressing absorption capacity. And because this is a hybrid system, obviously the patient needs to mobilize. It weighs in at 130 grams, obviously, as well. So that's quite light as well. The canister, which I've touched on, this is mainly used for, well, this is obviously used for the excess fluids that can be transferred from the dressing. So if the dressing starts to become saturated, you have this, which almost acts as a second reservoir to keep the dressing in place, but then remove the excess exudates. And the canister itself obviously can be changed by the clinician, the patient themselves as well when they're at home. What I want to show you here very quickly is a video that shows the Advanced Solo running at -125, 2 canisterless systems that actually run at -85 milligrams of mercury. And what you'll see in the bottom left-hand corner is these canisterless systems actually have a single lumen port that goes into the dressing, whereas the Advanced Solo has a dual lumen port. What you'll notice after 2.5 to sort of 3 days with the canisterless systems, the negative pressure starts to drop off and fundamentally stops. So basically what you end up with is a dressing. So it's not actually removing that exudate effectively as what you think. Whereas obviously you can see that the advanced solo continues for the 7 days, almost at the -125. So I've touched on the CFM technology. It's a combination of controlled airflow with the absorptive dressing and a distal canister. This enables the system, obviously, as I said, to deliver continuous regulated negative pressure whilst transporting the exudate to the dressing and the canister. Obviously, there's regular cycles every 25 to 30 seconds just to make sure that the pump ensures that it stays at optimum levels of negative pressure as well. The border dressing, absorptive dressing that actually conforms certainly to difficult areas such as hips, knees, shoulders, but it also retains the fluid within the dressing, obviously, even when the negative pressure is applied. And it also has a waterproof backing, which is very good, obviously, in terms of aid for the patient being able to get back in and mobilize and sort of shower, but obviously a bacterial barrier as well. SafeTac technology, which Mölnlycke are very well known for, it's been proven to minimize trauma to wound site and surrounding skin upon dressing removal. But when you're applying the dressing, it does make it possible to lift and readjust the dressing. This is before, obviously, fixation strips are applied. The front cover of itself, of the pump, very simple. It's audible and visual. Lets you know if there's a leak, if there's a blockage, or if the canister's full, just by audible. And as I said, it's visual as well. It's got the battery there in case there's any issues with that. What I really wanted to show you here, just before I finish, is that we've seen it in the past where dressings become very saturated. The initial thought is to remove the dressing and replace it. But because you've got a 50ml canister there, when the dressing becomes saturated, as I said, it still removes that excess exudate. So there is no need to remove that dressing, which is there for 7 days. And all you will need to do is, once the canister becomes full, is then just to change the canister and continue with the therapy. That's my presentation. Thank you very much. You're on mute, Rhidian.
Apologies, Dan. Thank you so much for that presentation, and again for sponsoring this webinar. And I'm sure you'll be available for questions, if not tonight, at any time the audience want to speak to you.
Yeah, of course, not a problem. Thank you.
Super. Thank you very much, Mölnlycke. And so on to our final speaker, Dr. Joshua Jones from Dundee. Josh, I've heard speak a couple of times now, and he really does know everything there is to know about phage therapy, and I'm certainly looking forward to his current presentation. Josh, if I could hand over to you, please.
Thanks, Rhidian. I don't know everything there is to know about Zoom. I couldn't find the right button. So let me just share my screen. Excellent. Okay, well, thanks very much for inviting me to speak. Conscious of time, so I'll try and keep this as short as possible. My name is Josh. I'm a clinical phage specialist and director of UK phage therapy. I've got a general interest in phage therapy for antibiotic refractory infections, but have also supported the treatment of 3 orthopaedic cases here in the UK. So I'm going to assume that lots of you have not heard of phages before. So phages are viruses, naturally occurring viruses that infect and kill bacteria. They look a bit like this. And phages are found wherever bacteria are found. So as we sit here, wherever you are in the world tonight, you are in contact with billions of phages. And it's estimated that there are 10 to the 31 phages on Earth. So when we think about those in terms of potential therapeutic agents, that's a mind-boggling number and potential combinations. And of course, we've co-evolved with phages over thousands of years. So we should keep that in mind when we think about how few side effects or adverse effects we see from phage therapy. So just briefly, the history of phage therapy is really interesting. We won't go into it in detail tonight, but effectively phage therapy had a golden age in the 1920s and 30s, where it was used quite widely, particularly in the West, but also in the geopolitical East. And that was really curtailed by two things: the mass production of antibiotics, but also a lack of knowledge really about what phages were at the time. So this is just to illustrate that phages can be used in two ways. A collection of phages can be used to produce pre-formulated off-the-shelf cocktails, and there's a picture here of one that you can buy in pharmacies in Georgia. But also you can use a collection of phages to create personalized phage preps for your patient's bacteria. So just to summarize some of the advantages, perhaps first and most obviously, phages offer bacterial killing independent of antibiotic resistance with no notable side effects. Other ones just to highlight tonight are the specificity of phages. Means they're considered to have minimal impact on commensal flora, unlike many of our antibiotics. Particularly relevant for PGI, some phages have antibiofilm activity, and phages and antibiotics can also synergize by producing or effectively putting two very different selection pressures onto bacteria. And there is clinical and in vitro evidence that of synergy, and phage therapy can in some cases resensitize bugs to antibiotics. And of course there's the potential for personalized medicine because of the diversity of phages. So we're a bit short on time, but the paper at the top has a good general discussion of the advantages and caveats of phage therapy. So moving on to the caveats, actually having a phage that will lyse or kill your bacteria of interest is not always straightforward, and when we've got polymicrobial infections, that becomes more challenging. We really want phages for all of them, if possible, or at least antibiotic coverage for the rest. Phages do have some drawbacks in the sense that their specificity, while good, obviously creates a very narrow host range, and that's overcome by using cocktails of phages. Bacteria can and do become resistant to phages, and again, the solution there is to fall back on the diversity of phages and switch those phages. And similarly, if we get neutralizing immune responses to phages. Perhaps a key challenge is actually the phages need to come into contact with the bacteria. So when you're thinking about this in terms of PGI, if you're doing a debridement and you're trying to do a phage washout in theatre, if you miss pockets of infection and you don't get phages or where they need to be, then that infection may well come back. So just to have a brief look at the evidence for phage therapy. So there is a lot of clinical data, clinical observational clinical case data in phage. So there have been around 2,500 cases published across a range of specialties. I've got some efficacy estimates from systematic reviews in the bottom left there, which look reasonably promising. Of course, these are patients largely whose infections were not treatable by antibiotics, and that body of clinical literature doesn't reveal any notable adverse effects. And there's a nice systematic review here published, I think in 2022, that covers just over 2,000 of those cases since the year 2000, and that identified really promising efficacy rates and found that the safety profile of phages was very promising indeed. And where they compared where the clinical trials they compared the control and phage groups, there were more adverse effects or adverse events in the control group. So we have this very promising, quite encouraging sort of body of observational data, but then we move to the clinical trials, and there are 13 clinical trials of phages since the year 2000. I think that's now up to 14 that have been published. So I need to update this slide. But all of those encouragingly have shown phages to be safe. However, of the 7 trials there that have looked at safety and efficacy, only 2 of those 7 trials have shown evidence of efficacy. So we have phage therapy suffers from an evidence paradox, where the clinical or the observational case data looks fantastic, but the clinical trial data really looks quite poor. And that paradox can be explained because phages simply aren't that straightforward to use. So you need to get enough of the right phages to the right place at the right time. So actually, if we get one bit of that constellation wrong, we won't get efficacy. And the bottom line is actually, if you read these papers, by their own admission, the 5 of the 7 trials there that haven't shown efficacy have missed one or more of those elements. And again, we're a bit short on time, but if you want a more detailed discussion, there's a paper at the top there. So encouragingly, the American Antibiotic Resistance Leadership Group, I think a couple of years ago now, published considerations for the use of phage therapy and effectively recommended that phage therapy be considered for difficult to treat infections. And as we've heard, that's also a growing area of interest in elsewhere in places like Canada. A couple of years later, Health Improvement Scotland, which is the Scottish equivalent of NICE, also carried out its own independent review of phage therapy for antibiotic refractory infections and came to a very similar conclusion. So in terms of interest and a global perspective, we've heard there is interest in Canada. There is growing global interest in phage therapy. Key sort of notable centres in Australia, Europe, Israel, the States, and it's a real sort of becoming a very hot topic in infection. In terms of the UK, we've been relatively slow to get going on phage therapy, largely because, in part, because of the lack of our own phage manufacturing. So all phage cases in the UK at the moment currently rely on imported phages. And this is because phages produced in the UK need to be made in accordance with a manufacturing standard called Good Manufacturing Practice, and that's not available in the UK yet. And we've also had a long-standing misconception that existing medicines regulations in the UK simply don't cater for phages because they're so different. And that's not the case. So at the top, you can see a snapshot of MHRA Guidance Note 14, which sets out the use or governance around the use of unlicensed medicines. And phage therapy, as any unlicensed medicine in the UK, can be considered where licensed alternatives are not meeting a patient's clinical needs, and that's governed by that MHRA guidance and your local trust's NHS unlicensed medicines policy. So far in the UK, we've had 2 patients receiving lengthy courses of antimycobacterial phage therapy at Great Ormond Street. And I have overseen the treatment of 10 diabetic foot infection and 3 orthopaedic patients as well. And that's been across 3 trusts. And I'm now running UK phage therapy, which is currently working with multiple trusts as a not-for-profit company to continue to make phage therapy available across the UK. So phage therapy has previously been quite difficult to access in the UK, but as I've said, building on my experience of delivering phage therapy across multiple trusts, I'm now providing a national clinical phage service through UK phage therapy to streamline that process for all trusts. If you are interested in accessing phage therapy for a patient, please do get in touch. Website and email are just here on the slide. So what we do is we support clinicians wanting to use phage therapy at every step, from the initial request right through to bedside. And we don't charge for this service, but there might be costs involved in acquiring phages from phage suppliers. So the time and costs involved will vary depending on the supplier, and that will depend on what your patient has in terms of bacteria. As a broad estimate, it can take anywhere between 2 to 12 months to organise and cost somewhere in the region of £3,000 to £10,000. But those costs, particularly if you're in the NHS, those costs should be covered by your trust's ULM budgets. We can't help you regarding patient selection, but I would strongly recommend looking at the Health Improvement Scotland guidance, which sets out 4 very broad criteria. So antibiotic resistance, antibiotic sensitivity, but clinical recalcitrance, which is quite an area of interest in the orthopaedic context, high risk of death or significant complications if surgical intervention is used to manage their infection, and a 4th sort of weird basket of patient-specific factors that preclude the use of conventional antibiotics, so allergy, intolerance, CKD, that sort of thing. So the sorts of orthopaedic requests that we've previously had include patients with effectively biofilms on infected metalwork, deep chronic recalcitrant infections with sinuses, or even a few patients with pan-resistant organisms. If you do want to discuss a patient, as I said, please do get in touch via the email address here and just include a brief history of pathogens and sites of infection, and we can take it from there. Ian, can I just ask, in terms of time, do you want me to stop there, or are you happy for me to carry on? I'm happy to stop.
Another couple of minutes, maybe, just to round things up.
So just a very quick look at future challenges. So as we saw earlier, we've got this evidence paradox in phage therapy, and that is something that really needs to be resolved. Phages do present challenges to the clinical trial model, particularly around the specificity of phages, the diversity of phages, but also the complicating factor in some cases that patients will be receiving ongoing antibiotics that might complicate the interpretation of outcomes. But it is encouraging to note that there are trials of phage therapy for bone and joint infections ongoing or planned, Belgium, France, the US, Australia. So I really hope that in a few years' time, we'll have a substantial body of compelling clinical trial data that will have resolved that present evidence paradox. And not just from orthopedics, but there are multiple clinical trials of phage therapy, of course, going on for other indications elsewhere as well. And it'd be lovely to see a clinical trial in the UK at some point too. Why aren't there any clinical trials in the UK? Well, that's a very good question. And the short answer is that trials in the UK need phages that are produced in accordance with good manufacturing practice, that manufacturing standard we alluded to earlier, GMP. And GMP phages are available. They can be contract manufactured, but they have been prohibitively expensive without commercial support. And that has really been the roadblock to trials here. And as I've said, the biggest barrier really to clinical trials is about almost total lack of private investment. And this is particularly acute with naturally occurring phage products. In contrast, engineered phage products are much more commercially attractive and are getting investment. For example, engineered phages came fourth in last year's World Economic Forum list of top 10 emerging technologies. So they're up there with things like clean fuel and AI and so on. So they really are getting some attention. But I really hope that increased commercial investment will help unblock some of the current challenges around manufacturing. So I'm not going to go through this slide in depth at all, but I just wanted to very briefly summarize some of the research questions, if anything, just to illustrate how much we really don't know. So, for example, there's a really limited knowledge about the best way to use phages, and a lot of variety in the way that phages are used in the literature, but simple things like dose, tissue penetration, and to add to the complexity, of course, these parameters might vary between phages. So I think there really are grounds to be optimistic about the potentially transformational impact of phages at all stages of the patient journey. And really, I hope that what that will translate into is better care for patients, but that'll also translate, I expect, into more savings for the NHS. So apologies if I've gone through that rather briskly, but I'll stop there. And thank you for your time.
Josh, once again, a really clear presentation on what is an emerging field, and I'm still staggered that £10,000 per treatment in the scale of PGI management actually isn't that great. Ian, I think we have some questions from the delegates.
Yes, so firstly, Josh, question, how do we deliver phage therapy? Is it systemic or local?
So that will depend on your patient. So the phage therapy is about not just having personalised phage preparations in some respects. So up here we had a patient with staph phage, but also a bespoke Klebsiella phage that had been specifically discovered from Hungarian sewage for this patient. So not just about having a personalised therapy, but also about having a personalised treatment plan. And that will depend on a case-by-case basis. In some cases, local administration, if possible, might be suitable. In other cases, we might want debridement and post-operative administration. In other cases, you might add IV to that. There are, in the literature for orthopaedic infection, there's a wide range of variation, broadly falling into IV with intraoperative or intraoperative only. There doesn't seem to be any particular difference in terms of which works better. And the odd case in the literature will even add in oral phage therapy. So there really is a variety, and it does depend on each case, has to be looked at on its own merits. Okay.
Next question, do phages work against fungal infections?
So unfortunately not. So phages are viruses or bacteria, unfortunately, not of fungal organisms.
Okay. Something I think you talked upon in the talk already, but what is the approximate timeline from requesting phage therapy to essentially implementing it?
Yeah, good question. So again, it depends on the bug and the complexity of your patient's infection. Can be as quick as something like 2 months, can be up to something like 12 months. Actually, probably one of the factors, one of the rate limiting steps in there is how fast your own trust will move in terms of moving their unlicensed medicines process along, and that varies quite a bit between trusts.
Okay, and just a last question. Along with the above question, do you believe there's a role in standardisation of phage therapy, for example, when, how, and quantity, to allow for better comparison of reported data and ongoing clinical trials?
So I think at the moment, as I've said, I think we are in a position where we have to, this is an unlicensed medicine, we have to treat each case on its own merits, both in terms of therapy and approach. We're a long way from being able to have standardized protocols as we do for antibiotics, and the diversity in both in as we've hinted in terms of treatment, but also in terms of the phage preps that may be used, may mean that even when we get to that point, we will still have quite very flexible guidelines. But I think in order to get to that point, we need to see much more compelling clinical trial data, and we certainly don't have the level of evidence, anywhere near the level of evidence that we currently do, to be approaching that at the moment. So I think it might be possible eventually to get to a very broad brush sort of guideline around treatment, but it's not going to be like antibiotics, I suspect.
Perfect. So whilst there are some more questions coming through for you, Josh, I think we'll draw things to a close there. I'm sure people can get in touch with you via the email address you provided for further questions. I'd like to extend our sincere thanks to all our invited speakers for sharing their expert insights into PJI. So Professor Fares Haddad, Dr. Simon Garceau, and yourself, Dr. Josh Jones. And of course, my co-host, Rhidian Morgan-Jones, for all his hard work behind the scenes with this webinar and BAJIS as a whole. We're grateful to our sponsor for their support, and of course everyone that signed in and actively participated in the discussions. Again, I would encourage you to join BAJIS if you haven't already. Membership is free and you can get a lot of valuable resources and updates. Please keep an eye out for us, our special session at the BOA Annual Congress in September as well. So thanks once again for joining us, and enjoy the rest of your evening.
Thank you.